Refractive accommodative esotropia with normal AC to A ratio is defined as an esotropia that is restored to orthotropia at all fixation distances and in all gaze positions by optical correction of the underlying hypermetropic refractive error. Most patients with uncorrected hypermetropia will attempt to clear the image blur by increasing accommodative effort that will, in turn, cause excessive accommodative convergence. If fusional divergence is insufficient to compensate for this impulse to converge the eyes and in the presence of a normal or high AC to A ratio, esotropia will develop. If fusional divergence amplitudes are sufficient to cope with the induced esodeviation, an esophoria will be produced. In the presence of a low or flat AC to A ratio, the patient may remain orthotropic since the convergence induced by excessive accommodation is normal or even subnormal. Such patients may develop a mild form of pattern deprivation amblyopia or ametropic amblyopia in both eyes. Therapy of refractive accommodative esotropia is full correction of the hypermetropic refractive error determined by cycloplegic refraction. That is usually all that is required initially for rehabilitation. Then, the cycloplegic refraction is repeated annually, and the glasses are adjusted when necessary. If the distance deviation is reduced or eliminated by glasses and esotropia remains at near fixation, then, a non-accommodative convergence excess is present. If the glasses only partially reduce the angle of strabismus at near and distance fixation, then, partially accommodative esotropia is present. The use of LASIK in the treatment of accommodative strabismus is being discussed with increasing frequency. At this stage of our knowledge we are opposed to this treatment in the pediatric age group. Non-refractive accommodative esotropia with high AC to A ratio is defined as an esotropia greater at near than at distance fixation, unrelated to an uncorrected refractive error. The etiology is closely linked with an abnormal synkinesis between accommodation and accommodative convergence. The effort to accommodate elicits an abnormally high accommodative convergence response. Since the near deviation is the primary obstacle to normal binocular vision in patients with non-refractive accommodative esotropia, the ideal treatment is with bifocal lenses. Hypoaccommodative esotropia is defined as an esotropia greater at near than at distance fixation, unrelated to an uncorrected hypermetropic refractive error and caused by excessive convergence from an increased accommodative effort to overcome a primary or secondary weakness of accommodation. It is characterized by a small refractive error, a remote near point of accommodation, a small deviation at distance fixation, but a large esotropia at near fixation. An esotropia is partially accommodative when accommodative factors contribute to but do not account for the entire deviation. A residual esotropia may exist despite full correction of a hypermetropic refractive error. Essential infantile esotropia is a manifest esodeviation with an onset between birth and 6 months of age. Consistent findings of essential infantile esotropia are large angle more than 30 degrees, initial alternation with crossed fixation, occasionally also very early fixation preference, no clinically apparent CNS involvement, and asymmetrical optokinetic nystagmus. Variable findings of essential infantile esotropia are amblyopia, apparently defective abduction, apparently excessive reduction, up or down shoot on adduction, A or V pattern, DVD, manifest latent nystagmus, manifest nystagmus, and anomalous head posture. Non-accommodative convergence excess esotropia with normal AC to A ratio is defined as an esotropia that is larger at near than at distance fixation in an optically fully corrected patient whose AC to A ratio is normal. Acquired or basic esotropia is a concomitant esotropia with a gradual onset after 6 months of age but usually limited to childhood and a near deviation that approximately equals the distance deviation. Esotropia in myopia. There are two special forms of esotropia occurring with myopia. The first type is an esotropia with limitation of abduction in both eyes, and normal adduction. The second type is caused by restrictive factors caused by the big size of the globe in high myopia. Acute acquired comitant esotropia may occur after interruption of fusion, which occurs in temporary occlusion of one eye as in treatment of amblyopia, corneal injury, and after excision of a chalazion. Microatropia. Ultrasmall angles of strabismus may escape diagnosis by ordinary methods of examination and are frequently overlooked. The cover test may be negative, or the fixation movement of the deviated eye may be absent or so small that it defies detection by the examiner when the sound eye is covered. Recurrent esotropia is a rare form of esotropia which recurs to the same angle despite multiple operations. Among the factors that could cause such a condition are uncorrected hypermetropia, anomalous retinal correspondence, nystagmus blockage by convergence, or a blind spot syndrome. Sensory esotropia. The most common causes are anisomtropia, injuries, corneal opacities, congenital or traumatic unilateral cataracts, macular lesions, and optic atrophy. Consecutive esotropia occurs almost exclusively iatrogenically after surgical overcorrection of an exodeviation.